Hi friends. So step 2 CK basically tests us upon the next best step in management of the common pathologies. And so over a series of videos I decided to make a simplified create a simplified approach by which we will be able to discern the next best step. So over next few videos we shall be discussing important topics in internal medicine and surgery, and today I shall be trying to tackle endocrine. So let us presume we have a patient with thyroid nodule. So in that case, the first thing after history and physical examination is to do a TSH and an ultrasound of the neck. Now, if the TSH is subnormal or low, or we can have a TSH that is normal or high. If the TSH is low, the next best step would be to do a thyroid scintigraphy. Now, in the scintigraphy, if we have a hot nodule or a functional nodule, the next best step would be to do a T3, T4 to rule out hyperthyroidism. But if the thyroid scintigraphy gives us a cold nodule or the TSH is normal or high, then in that case we'll look at the ultrasound neck findings that might be suggestive of a suspicious nodule. So what are those findings? Any suspicious nodule more than equal to 1 centimeter. Suspicious means having high vascularity, calcification, irregular borders. Or a large thyroid nodule which is defined as more than 1.5 centimeter, or any other risk factors for malignancy, like suppose there is a history of radiation in childhood. If any of this thing is present, if the answer is yes, then we should go for FNSC and cytology. If our answer is no, we'll just monitor via ultrasound. So this is our approach for thyroid nodule. Now let us get to the next topic, that is nipple discharge. So nipple discharge can be either physiological or pathological. A physiological nipple discharge is usually bilateral and milky in color. So we we term it as galactorrhea. Now if we have physiological nipple discharge, the next best step would be to measure prolactin level. If the prolactin level is normal, then we do not have to do anything else. We'll just follow up the patient. There's no pathological cause of galactorrhea here. But if the prolactin level is high, then it either can be because of it can be secondary to some endocrine or medical conditions, or it can be because of a prolactin secreting tumor. So in that case, if we are suspecting a prolactin secreting tumor, we'll do a MRI of the pituitary, because that's where the prolactin comes from. But before doing an MRI of the pituitary, we should definitely rule out hyperprolactinemia secondary to endocrine or medical causes. So what are the tests under this thing? We'll do serum TSH, beta HCG and creatinine. If TSH is high, that means the secondary, the hyperprolactinemia is because of hypothyroidism. If beta HCG is high, that means the prolactin is raised because of pregnancy. And if creatinine is high, that means prolactin is raised because of CKD or chronic renal failure. Now, if these things come out to be negative, then we are going to do MRI of the pituitary. Now, for pathological, that means unilateral discharge or any discharge that has a color different from white, then our modality of investigation would depend upon the age of the patient. If the patient is less than 30 years, we will go for subareolar USGs, areolar ultrasound. If the patient is more than 30 years, we will go for mammography plus ultrasound. And depending upon the findings, we will decide to do a biopsy or not. So this is how we tackle nipple discharge. The next topic would be a patient with suspected hyperaldosteronism. So in this case, the patient will be having hypertension, and from the findings, once we are suspecting that there might be a raised aldosterone level, the first thing to do would be to find out the ratio of plasma aldosterone concentration to plasma renin activity. We can have three categories of findings here. The plasma aldosterone concentration and plasma renin activity may both be raised. That means we have some condition in which renin is increasing, and because of the increase in renin, aldosterone is increasing. So what can be those conditions? They can be renal artery stenosis or a renin producing tumor or CKD, and can also be because of diuretic use and cirrhosis. So this is the first thing. Now, if the PSC by plasma renin activity is more than 20, that means aldosterone is high and renin is low. What does that mean? That means there is a source of aldosterone. So something is producing aldosterone, and since aldosterone has a negative feedback effect on renin, it is decreasing the renin activity. So somewhere there is a production of aldosterone. Now, in this case, we will have to go for a confirmatory test, that is oral salt loading and or saline infusion test. Oral salt loading or saline infusion test. If it is positive, then we have primary hyperaldosteronism, and we are going to do a CT scan of the adrenal to find out what kind of a adrenal tumor that is. But okay, we'll continue with this. The third thing would be the PSC to plasma renin activity. Both will be low actually. In that case, we are actually dealing with something called pseudo hyperaldosteronism, which is not very high yield for USMLE, but it's usually because of exogenous mineralocorticoid activity and can also be because of Cushing syndrome. Now let us just elaborate on this thing. CT scan of the adrenal. So if the PSC by plasma renin activity is more than 20, and by oral salt loading we confirm that this is primary hyperaldosteronism, then we are going to do a CT of the adrenal. If the CT is showing us signs of malignancy, then then we are going to do surgery. But if we do not have any signs of malignancy, we are going to do something called adrenal venous sampling. Adrenal venous sampling. And if the adrenal venous sampling shows us bilateral secretion, that means the adenoma is present in both the adrenals. In that case, we cannot do surgery because we cannot remove both the adrenals. So we have to treat with aldosterone receptor antagonists. But if it's a unilateral secretion of aldosterone, that means the adrenal adenoma is unilateral. In that case, we can go for surgery. So in malignancy, we directly went for surgery. In unilateral, we can do surgery. But if it is bilateral, we give aldosterone receptor antagonist, and in a malignant tumor, in a malignant mass, if the patient is not a good surgical candidate, we can also think of giving them aldosterone receptor antagonists. So this is how we tackle primary hyperaldosteronism. Now the next thing on our topic list is adrenal insufficiency. adrenal insufficiency. So adrenal insufficiency, the first thing would be to measure AM cortisol level and plasma ACTH. AM cortisol level and plasma, it is ACTH. After that, we do a 250 microgram cosyntrophin stimulation test. Now, as we all have already studied in test 1, if step 1, if it's an insufficiency, we'll go for stimulating, and if it is a high excessive state, we will go for suppression tests. So this is 250 microgram cosyntrophin stimulation test, and we will measure cortisol levels and ACTH levels after this cosyntrophin stimulation. Now, if the cortisol level is low as well as ACTH level is low, both are low. If the ACTH cortisol level is low and ACTH level is low, that means pituitary is not producing ACTH. That means it is a secondary cause of adrenal insufficiency. Secondary or tertiary. That means it might be pituitary or it might be the hypothalamus at play. Okay, if both are low. Now, if cortisol is low but ACTH is high, that means the adrenal is not producing cortisol, and because cortisol is not there is no negative feedback on ACTH, so ACTH levels are increasing. That means the problem here lies with the adrenal itself. So this is a case of primary adrenal insufficiency. A normal response, I forgot to mention, actually a normal response with cosyntrophin stimulation test would be an increase in the level of cortisol more than 20 microgram per deciliter after 1 hour of cosyntrophin. So this is how we diagnose or evaluate a patient with adrenal insufficiency. The next thing would be precocious puberty. So precocious puberty is the finding of secondary sexual characteristics in a female less than 8 years and males less than 9 years. The first thing to do here would be waist or hand X-ray. Now, if we have an advanced age here, what do we mean by that? More than 1 year difference between the born age and the chronological age. Then that means we are dealing with precocious puberty, and in that case we first measure LH levels. If the basal LH levels are high, then this is a case of central precocious puberty. In that case, we do a cranial MRI, and we may find a hypothalamic tumor or a CNS hematoma, something like that. But if the cranial ultrasound is negative and patient is obese, then we might be dealing with something called obesity related central precocious puberty. This is if there is advanced bone age. This is if the LH levels are high. Now, when you measure the LH levels and the LH levels are actually normal or low, then we go for something called GnRH stimulation test. GnRH stimulation. After GnRH stimulation, if the LH levels are increasing, then it is central precocious puberty, and then again we will go for cranial MRI. But after GnRH stimulation, if the LH level remains low, that means the problem lies with the ovaries or the testis. It is a case of peripheral precocious puberty or adrenal. So in this case, what we are going to do is a panel of hormones, DHES, estradiol, beta-HCG, 17-hydroxyprogesterone, and ultrasound of the abdomen. Now, in this waist and hand X-ray, if we find a normal bone age, that means we are dealing with either an isolated premature thelarchy or an isolated premature menarche. In this case, we just reassess the patient in 3 to 6 months. So this is how we approach a patient of precocious puberty. Now, the next thing on our agenda is Cushing syndrome. So, Cushing syndrome is basically, you can suspect a patient to have Cushing syndrome if they have 2 out of 3 of these lab values. 24-hour urinary free cortisol is high, or late night salivary cortisol is high, or 1 milligram overnight dexamethasone suppression of plasma cortisol is abnormal. That means if you are giving 1 milligram overnight dexamethasone, if you are giving 1 milligram dexamethasone and then testing for plasma cortisol, it should actually suppress it. But if it is not able to suppress it, then that is a positive dexamethasone suppression test. So out of 3 of these, 24-hour urinary free cortisol, late night salivary cortisol, and 1 milligram overnight dexamethasone suppression of plasma cortisol, if 2 are positive, then we are dealing with a case of Cushing syndrome. In that case, the first thing to do would be to measure plasma ACTH levels. If the plasma ACTH levels are low, then that means the source of the cortisol is the adrenal itself. In that case, we would go ahead and do a adrenal CT. But if the plasma ACTH levels are high or normal, in that case we are dealing with an ACTH dependent Cushing syndrome. So ACTH dependent Cushing syndrome, because ACTH comes from pituitary, we will go ahead and image the pituitary by MRI of the pituitary gland. If we have a adenoma, if you find a pituitary adenoma more than 6 millimeter, then this is our definition for Cushing's disease. If we find no mass or adenoma less than 6 millimeter, then we are going to go for something called petrosal sinus sampling. Petrosal sinus sampling, and if it is positive, then we are dealing with Cushing's disease. If the petrosal sinus sampling is negative, that means the source of ACTH is from an ectopic origin, like small cell carcinoma of the lungs. So this is how we deal with Cushing's syndrome. The next on our agenda is acromegaly. The first thing to do for acromegaly would be to measure serum insulin-like growth factor 1 levels. If it is normal, this is not a patient of acromegaly. But if it is high, we'll go forward with further testing. The next test would be to do a oral glucose tolerance test plus growth hormone. Now, growth hormone suppressed 2 hours after glucose. Growth hormone suppressed 2 hours after glucose. If it is not suppressed, you give glucose and growth hormone, test whether the growth hormone suppression 2 hours after glucose is present or not. Usually what happens is, I'll just back up here. You give glucose to a patient, the growth hormone should be suppressed. If it is not suppressed, that means this is a confirmed case of acromegaly. If it is suppressed, then you exclude. This is not acromegaly. Now, if it is a confirmed case of acromegaly, what we will do is we will do a MRI of the pituitary. If we find a visible mass, then is usually a growth hormone secreting pituitary adenoma. But if it is normal, we screen for extra pituitary causes of acromegaly. Okay, so this is how we deal with acromegaly. Now, what do we do when we have a case of suspected hyperthyroidism? So first thing, of course, we do a thyroid function test. Now, if the TSH is high, total T4, T3 is high and T4 is high, that means we are dealing with a thyrotrophic adenoma. And we should do a MRI of the pituitary in that case. If the TSH, because why this is so? Because TSH levels are high, that means the source of TSH is actually pituitary. So if TSH is high, T3 is high, T4 is high, all of them are high, then definitely the pituitary is at fault here. So MRI of the pituitary. But if the TSH levels are low and T3, T4 levels are high, then this is a case of overt hyperthyroidism and we should look for Graves' triad. So what do we have in Graves' triad? Goiter, exophthalmos and pretibial myxedema. If it is present, that means we are dealing with Graves' disease. But if we do not have Graves' triad, in that case we do a radioactive iodine uptake scan. Radioactive iodine uptake scan. In that case, if we have a high uptake, we have to look at the nature of the uptake. If it is diffusely increasing uptake, then it can be Graves. Again, it can be Graves without the classic Graves triad. But if the high uptake is actually nodular in pattern with only one nodule, then that might be a toxic adenoma. And if it is multiple nodules, then it may be multinodular goiter. Toxic multinodular goiter. But if the radioactive iodine uptake scan shows low uptake, that means we are dealing with a condition which is only transiently causing hyperthyroidism, but the activity of the thyroid gland is not increased. That means it is not an actual case of hyperthyroidism. It is a condition which is only temporarily causing hyperthyroidism. What are those conditions? They are early Hashimoto's or subacute thyroiditis. In these cases, when the thyroid gland, the autoantibodies act on the thyroid gland, they destroy the follicles and there is a temporary increase in the thyroid hormone level. So initially the patient present with hyperthyroidism and then euthyroidism and then hypothyroidism. And this is their natural course. Now in thyroid function test, if the TSH levels are low but we have normal T3 and T4, this means we are dealing with something called subclinical hyperthyroidism. So this is how we investigate a patient of hyperthyroidism. Okay, so the The last thing would be to no I huh yeah so the last thing would be to work up a case of suspected gastrinoma is basically GI, but since still gastrine, okay. Let us, if I started, let's do it. So if it's a suspected gastrinoma, we do endoscopy, and in endoscopy what we will find is multiple ulcers in the stomach and thickened gastric folds. The next thing would be to check the serum gastrin levels after the patient serum gastrin levels after the patient is off PPI for 1 week. Okay, so I think these are the important pathologies in endocrine and the diagnostic protocols for these. We'll try to do we'll try taking up a new system in the next video. Thank you.